I am Dr. Vijayalakshmi Thanasekaran from Chennai. I am a senior consultant. I had been in government service. I had been in Sri Ramachandra Medical College and Research Institute for 35 years as professor, head of the Department of Tuberculosis and Chest Diseases, and later as controller of examination of the same university. Now I am here to talk to you about the most common disease condition that we come across in our day-to-day practice. I am not going to talk to you about the US statistics. I am going to tell you about the Indian scenario. Let me take you through a case study. There is a family where there are two children, a boy and a girl, and now they are in their teens. The boy during the childhood days had been having wheeze and was taken to the pediatrician, and he was diagnosed to have asthma. But when he became an adolescent, his wheeze had almost controlled. But his sister did not have wheeze during the earlier days. Now during her teenage, now she has lots of wheeze. So the mother and the parents were very worried. They had taken her. Of course, an adolescent will go to a pediatrician. So the question here is, how is it that this girl did not have any problem in the earlier days, whereas the brother had problem? Here I want to tell you, the boys will manifest asthma in the earlier days. The girls might not have it because of the structural normality in the female and the males. Once these girls go into the adolescent stage, there are changes, anatomical and physiological changes, so they manifest with the wheeze. Now, how is it that these two children have wheeze? There's a family history of wheeze. Her mother had wheeze during the earlier days. So, indirectly stating that there is a familial tendency for asthma. That is number one. Now, the teenager, the boy does not have, the girl has. So, the girls manifest in the teenage or the adolescent period. And it is not only these two, but there are various other extraneous factors which can give rise to wheeze. Now, when I say wheeze, I mean that the body has so many systems, and one is the respiratory system, which has an upper airway and a lower airway. And these airways are lined with the mucous membrane, and you are all very familiar, you are all doctors, so you know what happens to the smooth muscle in the cartilage. So it is like a one disease. So upper airway, lower airway. So we know that when the air enters the nostril, humidification and warming up takes place, then goes, and when it reaches the terminal bronchioles and the airways, there is the problem. So the passage has to be patent. Now the problem is when there are various factors affecting. One is, the teenagers, the emotional factor. Two, as I told you, there is a familial factor already. Three, environmental factors. Now we are more interested in the environment. It is not only the indoor environment, air pollution, but also outdoor. And next is the exercise-induced asthma. We come across quite a lot of things. But here again, I just want to say that the upper airways can go in for spasm, and they can come to you in the emergency department with the wheeze. So never be carried away that this asthma is only lower airway disease and they will have only wheeze. No, upper airway problem also can give rise to wheeze, and so we have to be very careful in the diagnosis of asthma. And history taking is first and foremost important for all the practitioners. Please spend some time with the patient and the family and find out what is the triggering factor. Once you know the triggering factor, then everything is, you can come to a conclusion and manage the child, the adolescent girl. Here again, the emotional factor plays a major role. And third, exercise, as I told you, exercise-induced asthma. For some, it is a medication. Some are allergic to some medicines, and when they take some medicine, for instance, penicillin or sulfa, they can immediately go in for a bronchospasm. That is an emergency. Please remember to take the history properly. And the other factors are all, dust and all those things have to be considered. So when you think about this and then find out that, start examining the patient and you see that the patient has got these, okay, whether it is sibilant bronchi or whatever be the case, then first and foremost, as a chest physician, what we do is we have the lung function test assessed. And in our clinic, we have the peak expiratory flow rate, which we can use it and find out. And in this, after the thing, give a short-acting bronchodilator, wait for 12 to 15 minutes and repeat it. If there is a change more than 12% or 200 ml improvement, that means there is a very good response with the short-acting beta-2 agonist. So this I would like all of you to remember and follow in your practice, because anybody, a general practitioner, can also do it. So don't think it is only the chest physician who should do it. If you can have a lung function lab nearby, have the spirometry done, then assess it, you will know there is an improvement with the short-acting beta-2 agonist. But if there is no improvement, then you will have to think about other causes. Then, of course, now we are talking about a teenage girl, so there is, if it's the same with a teenage boy who smokes without his parents' knowledge or goes in for some chewing habits, he can go in for COPD, the chronic obstructive pulmonary disease. And there are various other factors. I'm not going to deal it because I'm going to confine myself with the asthma. And so, having diagnosed with the spirometry, a reversible airway disease, which we normally think in terms of bronchial asthma, responding to a short-acting beta-2 agonist. It's very good and the patient will have a good relief. Okay, having done that, how should I manage the girl? That is more important. Don't dump every child as a psychiatric case. When they are emotionally upset, it is for us to give the counseling and also treat the underlying problem, because emotion is a factor in the adolescent age group. Of course, for the adults, it's a different way. Here, what is the line of management that I am going to do after my spirometry? I will definitely go in for an inhaler. Now, once you doctors tell the patient or the relatives about the inhaler, the immediate question that will be asked to you is, should my child be having the inhaler till her life, as long as she lives? Now, just convince the parents first that it is not like that. It is a controllable disease, but never use the word curable disease. It's a well-controllable disease, and so the child should be given a good relief and then maintained with a controllable drugs. See, then they'll ask, doctor, are you going to give steroids to my child? You just tell them, if the child needs and if the child has to get relieved, she will be getting steroids. Then how long? And there are so many side effects because she's a teenager. You just tell the parents, nothing to get worried. This is a small dose of steroid which will be given in the form of an inhaler, and that is not going to give rise to any side effects. Doctor, how long? That will be the question asked to you all, because you are in the general practice, and that will be the layman's question to you. So you tell them, nothing to get worried. This is a small dose, and we need the child to be comfortable. So we give the inhaler, corticosteroid inhaler. Doctor, how long should my child take both these medicines? Now we have so many combinations coming as a single inhaler. But please teach your patient and the attenders the technique of using the inhaler. That is more important rather than just prescribing, asking them to go and buy and asking them to read the manual and then follow. Please, my advice to my junior colleagues and senior colleagues is, just have a technologist to teach the technique of using the inhaler. That is most important. Okay, now my child is relieved with your short-acting beta-2 agonist, salbutamol and anticholinergic ipratropium. Now what should I do next? Just wait. If there is an exacerbation or every winter she gets, then before the winter, you start the short-acting beta-2 agonist and then have a controller medication. Doctor, will my child, the other question is, will my child get every year during the winter or summer? You tell them some are prone during summer, some are prone during the winter, some will have early morning wheeze, some will not have. Doctor, will there be only wheeze? My dear friends, I just want to tell you, now all wheezers are not asthmatics. Please remember that. All wheezers are not asthmatics. Similarly, an asthmatic need not have wheeze. They can have dry cough, bronchial hyperreactivity. So they will be coughing. Early morning cough, or after, say for instance, talking for a long time, they might go in for dry cough and wheeze. And gastroesophageal reflux syndrome has to be kept in mind by all of you. People think that the specialists are writing what is this pantoprazole and other things. It's not like that, because GERD is also one of the cause for the wheeze. So remember all the causes for the wheeze and try to exclude, and then finally give a diagnosis of bronchial asthma. Do not dump anybody just like that, nor do you give your patient or the parents saying that, oh, this is a curable disease. Don't get worried. Never use the word curable to a bronchial asthmatic patient nor the relatives. It's a controllable disease, because now the adolescent girl has got it. She will be controlled well with the immediate or the reliever medications and controllable medications, which are long-acting beta-2 agonists with an inhaled corticosteroid. If due to some infection, say for instance, we had during our COVID period and post-COVID, during every viral season, we get people coming with a wheeze, because that triggers the mucosa and they go in for spasm. So these are the occasions. So history taking is very important, then investigations, then the management, and how long will the patient have to take the controlled medication like the long-acting beta-2 agonist, which can be salmeterol, formoterol group, or now we have got quite a lot of new medications, inhalers available, both as dry powder inhaler and as a MDI. So the technique of using the inhaler is very important, and you as physicians have to convince the patient that nothing to get worried at the moment, we will take care of it. But when there is exacerbation, they have to come to the hospital and see their pulse oximeter and how they are, because it is very, very important. People just forget, and during the COVID time, we had lots and lots of patients, and the saturation was very low, and they had to be admitted as well. So let us not go into that stage. Before that itself, let us control the wheeze. And I like something like this, one airway concept. And people like you and me should always remember the upper airways. Okay, upper airway, rhinitis, sinusitis. These are the triggers that a child or an adult can go in for bronchial asthma. So one airway concept has to be kept in mind, and I'm sure all of you will be seeing allergic rhinitis, but you will immediately send to the ENT person. Remember, it's a one airway disease, and allergic rhinitis, sinusitis can give rise to bronchial asthma. And my advice to all my colleagues is, do not dump everybody as a bronchial asthmatic. Take proper history, investigate with the spirometry, manage with bronchodilators and steroids, and counseling, and that is the best thing that I would like to tell all my junior colleagues. Okay.